Welcome back, everyone. We'll proceed to the final session before public comment on rabies vaccines, and I will ask Dr. Fry to please begin the introduction. Dr. Fry, if you will.
Thank you, Dr. Romero. Okay, good afternoon. We're going to talk about the rabies vaccine working group processes that we have done since we met last. We'll give you an update on that. Next slide, please. But first, I'd like to thank Lynn Bata, who's my co-member, all our liaison representatives, and our invited consultants. I want to give a shout out to Agam Rao and also the other leads that I have spoken with, have worked with closely, and all the other leads I have observed. It's amazing to me. Their leadership skills are outstanding. And when we keep in mind that what they do for the working group is just a small part, or it's a part of the pie, if you will, of all the other major demands that are on them, it's impressive how they get the work done that they do get done. And they do it extremely well. So thank you and all the CDC people related to this working group. Thank you. Next slide. Okay, so we're going to talk a little bit about what happened since the last meeting. In May, we provided presentations on the rabies pre-exposure prophylaxis as it relates to children. We talked about antibody response to rabies vaccine in children of all ages being similar to that of the adult. And also, I do want to mention that our working group's preference is for the PrEP recommendations for children to align with those of adults as they have in the past. We also presented information on PEP, post-exposure prophylaxis, and that included components of rabies PEP for previously vaccinated and naive persons, and factors that would be or should be considered before administering PEP. And we showed you a draft flow chart, which was discussed. Since that time, the working group has discussed RIG, which is rabies immunoglobulin products that have been licensed since the 2008 ACIP recommendations were made. And we also began discussions about changes to the PEP schedule. Next slide, please. So our goals for today are to talk about PrEP, and we will have a vote on that today, and then also talk about PEP. So for PrEP, we will review the evidence to recommendations framework presented at the October ACIP meeting and summarized at the February ACIP meeting. We will then have ACIP votes on 2 recommendations for children, and these are essentially the same recommendations we made for persons greater than 18 years of age during the February ACIP meeting. We will present information on PEP, particularly RIG. We'll provide background information on 2 products that have been licensed since 2008. And again, our working group consideration of recent changes to the WHO recommendations, and also data about changes to the PEP series and the working group's preference. There's no vote on PEP today. Next, please. So our anticipated timeline is presented here. If we jump to October, you can see that we will talk about PEP clinical guidance topics, and these will include the management of PEP, including the scheduled deviations for PrEP and PEP, and also PEP initiated abroad. Next slide, please. So today's presentations will all be provided by Dr. Agam Rao, and will include rabies immunoglobulin post-exposure prophylaxis schedule and rabies pre-exposure prophylaxis, a review of the summarized ETR. Next slide, please. Today's proposed recommendation, number one, is ACIP recommends a 2-dose, that is 0 and 7 days, intramuscular rabies vaccine series in immunocompetent persons less than 18 years of age for whom rabies vaccine pre-exposure prophylaxis or PrEP is indicated. Next slide, please. And the recommendation 2 is ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent persons less than 18 years of age who have sustained an elevated risk for only recognized rabies exposure. That is those in risk category 3 of the rabies PrEP recommendations table. The booster dose should be administered no sooner than 21 days, but no later than 3 years after the second dose of PrEP series. Next slide, please. This is a quick look at that chart that we showed you last time and we worked on and made some changes based on your recommendations. But we are interested in the second recommendation is for elevated risk. Look at number 3, please. Elevated risk of recognized exposures that is sustained. You can see below that for number 4, it's elevated risk of recognized exposures that elevated risk that is not sustained, that is less than 3 years. So we're interested in number 3 today. We'll go into more detail about this later. Next slide, please. And thank you for your attention. Thanks.
Thank you very much, Dr. Fry. Somebody has their microphone on. We're getting feedback here. Okay. Next, we'll go on to Dr. Rao, who will present rabies immune globulin prophylaxis. And Dr. Rao, do you want to take questions after each session? She will. Thank you very much.
Great. Thank you. So just a review of the viral pathogenesis of rabies. Rabies virus is a neurotropic virus. It enters the peripheral nerves. It travels centripetally to the central nervous system and then flows centrifugally to the innervated organs, including the salivary glands. And this image here on the right actually depicts that. The incubation period is usually weeks to months, but it can be longer, and death typically occurs within 2 weeks of illness onset. So what RIG does, or the role of rabies immune globulin, or RIG, in preventing rabies is that it provides passive immunity before the vaccine-induced humoral immunity occurs. And that vaccine-induced humoral immunity is from the 3 doses of rabies vaccine given as part of PEP. It is only given to persons who have not received pre-exposure prophylaxis or PrEP or previous PEP because those are the only people who would benefit from it, and also because RIG can decrease antibody titer levels from rabies vaccine. RIG does not negate the need for PEP vaccine series because at least some rabies virus is expected to travel to the CNS despite that passive neutralization. So RIG is indicated for 2 scenarios, and on this slide I'm showing one of those scenarios. It is persons who did not previously receive a complete series of recommended PrEP or PEP. On this line at the bottom here, you can see age and years of an individual who has no rabies exposures during their lifetime until at one point has their first and only rabies exposure, which results in wound washing, and PEP, which is RIG and the 4-dose PEP series. The second scenario is the one that I'll show you on this slide here. It is for persons who received a previous 2-dose series, but no booster or titer check per the ACIP recommendations that were approved during the February ACIP meeting. And here shown, the line below is the time since the 2-dose PrEP series. And if PrEP was previously received on days 0 and 7, which is shown on the left side of the line, the recipient is considered previously immunized for up to 3 years. But again, according to the newly passed ACIP recommendations at the February meeting, if such persons have an exposure beyond 3 years, then they would be managed the same as a person who had not been previously immunized, just for the sake of being conservative, given we don't have any data about immunogenicity beyond 3 years unless that titer or booster is checked. So they'd be managed the same as a person who had not been previously immunized, and that for that reason they would also receive RIG. The next two slides are another way of explaining the role of RIG. So on the x-axis is days after an exposure, and on the y-axis is rabies virus concentration. If a rabies exposure occurs, then there's virus present at the bite site. And if PEP, including RIG, is not administered, then there's the spread and replication of the virus in the CNS and salivary glands as shown here. And then once this occurs, there's onset of the rabies prodrome, acute neurologic period, coma, and death corresponding with the period of virus replication. On the other hand, if when a rabies exposure occurs, RIG is administered, then there is some virus neutralization at the inoculation site. And when rabies vaccine is administered according to the recommended IM 03714 day schedule, then there is vaccine-induced humoral response, and that's shown here. And there are no signs or symptoms of rabies that occur in a person. So at the time of the 2008 ACIP recommendations, which are the most recent recommendations for prevention of rabies, there were 2 RIG products licensed in the United States. Both were considered equally efficacious, and there was no preferential recommendation, and those were Hyperrab SD and Imagam. RIG administration in those recommendations was the same as it has been. It was for it to be administered within the first 7 days of the first vaccine dose being given, and for it to be administered at 20 IUs per kilogram regardless of age. Infiltration of the maximal amount of that RIG was to be given around the wound as much as is anatomically feasible, and then the remainder was recommended to be given intramuscularly at a location different from where vaccine was given. And then, of course, for large or multiple wounds, that RIG can be diluted in order to ensure that there's appropriate infiltration of as many wounds as possible. Now, since then, in 2018, WHO updated their recommendations, and their considerations for RIG recommendations included 2 factors that are not major concerns for the ACIP recommendations. Those are first that RIG is limited in supply internationally. It is estimated that worldwide approximately less than 2% of persons with serious wounds, or what WHO calls a category 3 wound, receive RIG. And RIG is also extremely expensive. It's much more expensive than the vaccine, and even persons in the US, just given just how expensive it is, have concerns about that. And second, dog bites are the most common rabies exposures, and dog bites are the most common rabies exposures worldwide, and those wounds are large. So a lot of the calculated RIG is probably able to be given around the wound, and the benefits from an IM administration of the RIG may be limited, and there might be some savings instead. So the 2018 WHO position statement prioritizes, for that reason, because RIG is limited in availability to persons who have the most concerning exposures. So those with high-risk exposures, multiple bites, deep wounds, bites to highly innervated body parts, persons with severe immunodeficiency, exposures from confirmed or probable rabies, rabid mammals, and exposures from bats in particular. It also, and this is perhaps the most notable portion here for our purposes, is that it limits the RIG infiltration to RIG that can be infiltrated into and around the wound only, and no longer has the recommendation for intramuscular administration of the leftover RIG. The maximal dose is still the same at 20 IUs per kilogram, and dilution of RIG is still recommended if there are multiple wounds. So here's the list of RIG products licensed in the United States, and the 2 highlighted ones, Kedrab and Hyperrab, were the ones that have been licensed since the 2008 ACIP recommendations. Hyperrab is actually, Hyperrab SD, which is very similar in name to the newly licensed Hyperrab, is being phased out, and so it still may be on the shelves of individual suppliers and hospitals, but there's no new product that's being sent out. So that really leaves just 3 products that are available. And of note, HyperRab is twice the potency of the other licensed products. So care needs to be taken in knowing which product a specific hospital is using. And so all of this leads us to the work group considerations for this ACIP update about RIG. Number one, there are 2 newly licensed RIG products. Are these new formulations of existing products or completely new products different from the previous? Number 2, regarding RIG administration limited to the wound, what is the data? And since in the U.S. exposure wounds are often small, like from a bat, what are the U.S. implications to that recommendation? And then finally, is there data to support any other changes to the RIG recommendations? And for the remainder of this presentation, I'll present the workgroup assessment of each of these separately. So I'll start with newly licensed RIG products in the United States. So as I previously mentioned, there are 2, the 2 highlighted are the 2 products that have been licensed since the 2008 ACIP recommendations came out. Kedrab and HyperRab actually make up most of the market share for rabies immune globulin and have no difficulty filling any gaps whenever there have been shortages of other products. Kedrab, to start with, Kedrab was licensed by FDA in 2017. It's indicated for passive transient post-exposure prophylaxis. It's supposed to be given to people of all ages and should be given immediately after contact with a rabid or possibly rabid animal. The clinical study design and trial results were similar to previously licensed RIG products, and so there were really no concerns when FDA reviewed it, and there was no referral of the BLA submission to the Blood Products Advisory Committee because there were no concerns or controversial issues that would have benefited from the advisory committee discussion. It was thought to be very similar to the other licensed RIG products. Now, HyperRab was licensed by FDA in 2018. It's indicated for PEP along with rabies vaccine as well. And this product, like I've mentioned, is a higher potency formulation of the previous HyperRab SD. So a greater concentration of anti-rabies virus antibodies can be given with each milliliter of volume, which means that less volume is needed to administer the recommended 20 IUs per kilogram. Twice the potency of currently available rabies immune globulins. There's no FDA post-licensure requirements because it is considered to be a new formulation rather than a new product. And it has improved production and manufacturing processes over the years and now requires dilution with dextrose 5% in water or D5W rather than normal saline. And I've highlighted that here in this slide because that is an important thing, important difference for this RIG product compared to the others, and is something that clinicians are going to need to be mindful of when administering it. So the work group assessed both of these new products. They're both prepared from plasma of donors who were hyperimmunized with rabies vaccine. The safety and efficacy are similar to the previously licensed RIG products. And the work group conclusions, after extensive discussion, we've had at least 3 work group meetings dedicated to this, was that the newly licensed products are not actually new. It's desirable to have multiple licensed RIG products because shortages have occurred, including within the last few years while we've been presenting to the ACIP. HyperRab is twice as concentrated, resulting in less volume administered compared to other RIGs. The products, though, are equally efficacious, so the work group had no preferential recommendation of a specific RIG product. As far as selection of a RIG product goes, the indications are same for all of them. The more concentrated product could potentially be preferable for small wounds like those from a bat bite. And given differences in potency between the products, oversight is obviously needed to ensure that the correct volume is administered for a particular product. There could be errors made and twice the volume inadvertently administered if care isn't taken to recognize the fact that one is more concentrated. Clinicians should be aware that D5W is the recommended diluent for HyperRab, even though it's not provided with the product. And then it's really up to individual facilities to decide which product they want to stock. We've learned that facilities typically just stock one product over any others. Now, moving on to the second topic that we discussed in detail, the work group discussions about RIG administration around the wound. So the role for RIG, studies indicate that it can be advantageous for people before they develop indigenous antibodies. It's not difficult to access in the US, unlike many other countries. Most rabies cases in the US are from bat exposures, and these create small or barely visible wounds, so very little RIG is administered around a wound, making any recommendations about limiting it to just around the wound, ones that need to be made very carefully. Immunogenicity data, though, suggests that IM RIG is detected in sera about 24 hours later, so there may be a benefit given that it is in the serum. As far as pathophysiology goes, RIG infiltrated around the wound likely remains at that site of the injection. There is limited data cited in the WHO position statement with the references listed on this slide, explaining WHO's decision to limit RIG to infiltration around the wound. It's unclear whether IM administration of RIG provides a significant benefit from their assessment, but it was based on very limited data. And the work group felt that the data was insufficient for the work group to propose the same recommendations to the ACIP. So these are as far as the two newly licensed RIG products go, are these new formulations or new products? The work group concluded that these are new formulations. RIG administration limited to the wound. What is the data? WHO's considerations are obviously very different from those of ACIP given the population that they're working with. Small wounds would result in very small, if any, RIG infiltration around the wound, and so the implications to the U.S. population by limiting RIG administration to the wound would be significant potentially, because no intramuscular administration would mean that we would not see that same level in the bloodstream. Is there data to support any other changes to RIG recommendations? There's no changes to any RIG recommendations for the purposes of voting, but we have quite a lot of clinical guidance that will be presented during the October ACIP meeting about RIG, but also about PEP in general. And some of that includes inadvertent administration of a higher amount of RIG because of a hyperconcentrated product, or for other reasons which do happen. For example, sometimes people will administer RIG, all of the RIG intramuscularly, and then realize that they were supposed to first administer as much as possible around the wound, and so there can be extra RIG administered. And so those clinical guidance issues will be taken up by the work group. There are no other proposed recommendations that would require a vote. I'd like to thank the Rabies work group for the many discussions we had on this topic. Like I mentioned, we had at least 3 work group meetings dedicated to all of these topics, and also to the manufacturers of the newly licensed RIG products who were available to us for all the questions that we had, and provided a lot of data to us so that we could discuss in more detail. And I guess I can take any questions. Thank you.
Thank you very much, Dr. Rao. We are open for questions. Any of the liaisons wish to make a comment or ask a question? Dr. Talbot.
Yes, I had a quick question, and I didn't know how much information was available. Patients present in variable amounts of time to the emergency department or their primary care provider following a bite concerning for rabies. Is there any information on duration of time between bite and presentation that would impact the administration of the immunoglobulin just at the site versus at the site and elsewhere to improve maybe the systemic number of antibodies, since the infection probably would progress the longer the time to presentation?
Yeah, thank you, Dr. Talbot. So I'll ask Dr. Jesse Blanton to weigh in after I say a little bit about this. He's the subject matter expert on the CDC subject matter expert who's going to assist here. But it's whatever whatever virus is at the inoculation site, it takes some time before it travels upwards. And so we really haven't provided any limit to when rabies post-exposure prophylaxis can be administered after an exposure occurs. Rabies immunoglobulin should, however, be administered within 7 days of the rabies vaccine. The reason being that the RIG can actually bind to the antibodies in the vaccine and lower, and antibody levels can be lower than would otherwise occur. And so there's really no value to RIG administration beyond 7 days because humoral immunity would have mounted at that point, and there's really no benefit and only the potential disadvantage. But Dr. Blanton, would you like to say anything else about specific studies or anything else that you want to weigh in on that question?
Thanks, Autumn. I think you addressed well. It's a really good question, and one that unfortunately there's not a lot of very good data on, and certainly one reason why it is felt that sort of broad intramuscular and diffuse movement of the RIG provides some benefit in those sort of scenarios. But certainly after the increasing amount of time after a bite, the relative benefit of direct infiltration around the wound sort of decreases in the relative value of that.
I think that's all the questions that are at this time. Anyone else? Okay. Dr. Rao, do you need a break or should we keep going? She's motioning for us to keep going. So rabies post-prophylaxis schedule.
So this slide has previously been shown to the ACIP. It's just a reminder that the PEP vaccine schedule for naive persons is RIG plus vaccine on day 0, whatever day 0 might be, and then 3 more IM doses on days 3, 7, and 14. Next slide. The features of an approved PEP schedule are listed here on this slide. Effectiveness unchanged from the currently recommended series, fewer doses than the current 4-dose schedule, a completion of the series sooner than the current schedule, and ideally an intravascular vaccine schedule because that is what is used in the US, and also robust data supporting its use. Now, this would be our expectations as a work group for qualities in if we were to suggest any changes to the post-exposure prophylaxis schedule. Next. So this is a screenshot from a table in the recent WHO recommendations. WHO categorizes exposures into categories where category 1 is not really an exposure. It's licking of wounds. It's not a rabies exposure and therefore doesn't require PEP. It's a licking of skin, of intact skin. Category 2 is a mild exposure and category 3 is a more severe exposure. In category 2 would be some nibbling of the intact skin or a minor scratch without bleeding. And in number 3 would be a transdermal bite, for example. So the vaccine recommendations are the same for both category 2 and category 3. Next. In the red box are the recommendations for persons who were not previously immunized, i.e. did not receive PEP or PrEP in the past. In the yellow box, if we click here, is the recommended PEP schedules. And you can see there are multiple recommended schedules, but the ones that could be an improvement on the current ACIP recommendations is the one that you'll see in a green box. Next. There we go. That series would translate to a 3-dose IM PEP schedule at days 0, 3, and 7 days, which is shorter, 1 dose shorter than the current schedule, and it's completed a week sooner than the current schedule. Next. And then here at the bottom, just showing you that for previously immunized individuals of all age groups, the recommendations by WHO are the same as those of the ACIP, which is a two-dose vaccine series and no RIG. Next. So the work group wanted to look at this particular series that was taken on by the WHO in the form of intradermal recommendations. And so we reviewed a systematic review that was published just 2 years ago that evaluated multiple abridged PEP schedules. Next. The part of this systematic review, so the objective of this systematic review was to inform 2018 WHO update for rabies PEP schedules by evaluating 3 things here. The first is the issue that is most important to us. Next. It is immunogenicity and effectiveness of PEP schedules of a reduced dose and duration. The other things that this systematic review evaluated for are not important to the ACIP, but they were looking for new evidence on effective PEP protocols for special populations and effective changing routes of administration during a single course of PEP on the immunogenicity of PEP. Next. So the work group considered the following as they assessed the studies. The current ACIP PEP schedules have not been problematic. The cost considerations are less critical than they are for WHO. And again, the expectations, if there was going to be any change, are that a lot of things exist in any of the studies. There'd be a high seroconversion rate, effectiveness for all population types, large number of subjects, impact of RIG on antibody levels needs to be assessed in the studies. Vaccines would ideally be ones that are used in the US. The route of administration has to be convertible to an intramuscular recommendation, since that is what we use in the US. And if PEP was administered after an exposure, the animal causing the exposure should be confirmed to be rabid in situations where titers in particular are not evaluated. Next. So these are just some of the studies that we assessed as a work group, and I'll be quick about going through this. The work group spent a lot of time thinking about this, but just to point out, there were some issues with the schedules that we evaluated. I'm only showing the ones that involved a potential improvement from the existing 4-dose series. The 3 studies shown on this slide all involved an intradermal 037-day schedule, so a completion of the entire PEP series within a week. And in red, you can see some of the issues that prevented the work group from moving forward with these. Each of these 3 involved a 4-site intradermal series, and it's hard to convert that to intramuscular. They also involved PVRV vaccine, which is purified vero cell rabies vaccine, which is a cell culture vaccine that is thought to be equally efficacious to the vaccines available in the US. But it isn't a vaccine that's available in the US. And then there were other issues that you can see in red where only adults were evaluated, or the impact of RIG on the series was not assessed. And so for all of these reasons, the work group didn't feel like bringing forward a recommendation for shortening the series. But on the next slide, you'll see the main study that informed WHO's recommendations, and that is this Tarantola study from 2019. This was a 2-site each day study, so it was different from the ones that I've showed you on the previous slide. That 2-site intradermal can be roughly translated to an 1-dose intramuscular, which is what we did when we had discussions with you about the pre-exposure vaccination schedule. PVRV was again used in this study, but the bigger issue here is that of the 2,805 subjects that were included in this study, only 129 of the ones who got the 3-dose series instead of a 4-dose series were people who had exposures to confirmed rabid animals. And so because there were no titers checked in the study to confirm, because of just like the amount of the funding that was given, this was a concern that the work group had, and also the authors themselves. The authors recommended a clinical follow-up system be adopted by rabies prevention centers, especially to monitor implementation of any abridged course, including the one that they described in their study. It is a balance of costs and resources and feasibility, and the authors of this paper mentioned that adopting this abridged series would result in 25% fewer costs, 33% more people treated with the same amount of vaccine, and then the benefits to the patient would be fewer patient resources and time spent for travel and loss in daily wages, less patient crowding and high throughput clinics, and then increased equity. All are issues that are very important to the international population, but less so for the United States. And you can see here in this last column, the low power for the outcome of importance was noted by the authors of that systematic review. Next slide. So the work group then concluded, based on reviewing all of this information, that more studies are needed before a change can be proposed to the current 4-dose IM series. The studies that we're hoping people will conduct are ones with the features that I've mentioned down here, and also multiple times previously in this presentation. There's unfortunately a dearth of data to inform this. Next slide. So I want to move on to clinical guidance. The October ACIP meeting will be dedicated to us speaking about clinical guidance issues pertaining to post-exposure prophylaxis. But we did want to bring up one issue for, in case there's discussion during today's meeting. Next slide. The ACIP has general best practice guidelines for persons with altered immunocompetence, and in these, it is the clinician who determines who is immunocompromised. Next slide. The inactivated vaccines in immunocompromised persons, according to these best practice guidelines, there are no safety concerns, and the immune response, however, may be inadequate. So options for pre-exposure rabies prophylaxis have been to either delay PrEP until the person is no longer immunocompromised, or consider avoiding activities for which rabies PrEP is indicated. Alternatively, if PrEP has to be administered, it can be administered per the same schedule as healthy persons, but virus neutralizing antibody titers should be checked and boosters given if the titers are lower than the minimum antibody titer threshold. Next slide. Now for post-exposure prophylaxis, it's a little bit more complicated. The ACIP recommendations from 2008 still say to avoid immunosuppressive agents during the administration of PEP unless essential for the treatment of other conditions. And when PEP is administered to immunocompromised persons, one or more serum samples have to be obtained for rabies virus neutralizing antibody to ensure acceptable antibody response. And the ACIP recommendations say that if the titer is low upon checking, then there needs to be consultation with public health. Public health typically recommends booster doses until adequate titers are reached, and some patients will require multiple titers, but most do not. Next slide. I want to bring up that there was a 2010 update to the ACIP recommendations. So the 2008 ACIP recommendations actually recommended a 5-dose series. And the same PEP series was recommended for healthy persons and immunocompromised. And a titer check after completion of the series was only recommended for immunocompromised, which is the same as what has always been the case. And then in 2010, there was an update prompted by a shortage in rabies vaccine. And that updated process basically involved assessing the data for a 4-dose PEP series and found it to be effective. A 4-dose series replaced the 5-dose series for healthy persons, but there wasn't a change made to the immunocompromised group, even though previously the recommendations for healthy persons and immunocompromised have been in sync, and the only difference between the two was the requirement of the titer. Next slide. So the work group considerations about immunocompromised is that for immunocompromised, ACIP has always recommended titer checks after completion of the series. More vaccine doses and more titer checks may be indicated accordingly, but since a titer check is needed regardless of what schedule an immunocompromised person receives, the work group brought up the idea of a titer check with the 4th dose, which is sooner than the current guidance. And that has advantages, and that's why it was proposed. It might spare some persons from unnecessary additional doses. The recommendations for healthy and immunocompromised would be similar, except that the immunocompromised people would still need that titer check. And there's expected to be no negative impact on patient care because that titer would still be what is used in order to determine whether or not additional doses should be given. The PEP services, I just want to explain very quickly, the reason that with a 4th dose is being recommended is that a person who gets pre-exposure prophylaxis can generate an anamnestic response in 2 to 3 days, but it usually takes longer for post-exposure prophylaxis. And because PEP is priming the immune response in a naive person, so it's a slower response, but you have an immediate need for high neutralizing antibody levels. And most people in clinical trials typically...
You are muted. You can mute or unmute yourself by pressing *6.
If you can hear us, we're looking into the problem. Can you hear me now?
Our room's muted.
Not anymore, it should be wide open.
Okay. Well, she just came on all of a sudden.
Yeah.
Yeah, somebody muted.
Did I hear a yes? I'm sorry.
Yeah.
Okay,
Yes.
we'll try again. We're not sure why we lost the sound there. Thank you very much.
The last thing we heard was no negative impact on patient care.
Repeat that again one more time.
No negative impact on patient care.
Thank you very much.
Okay, thank you. I heard that. So what I'd said after that was just that I wanted to explain that in the clinical trials, most people, including immunocompromised people, typically have titers that are at the appropriate level after 3 doses. And that's why checking a titer with the 4th dose will probably spare a lot of people from getting additional doses. Additionally, the whole criteria of determining if somebody is immunocompromised is really dependent on the clinician. And so this too, just checking a titer with the 4th dose would be given to all patients regardless of whether they are immunocompromised or not. It prevents people from getting an additional extra dose if not needed. And there is, actually on the next slide, there is otherwise, titers for immunocompromised persons would be checked after completion of the PEP series. Titers would be checked with the 4th dose, as I said, and you can get expedited titer checks whenever clinicians contact one of the 3 labs where these titer checks take place. It's a common thing to request the titers to be expedited, and they can be reported back within 48 hours when clinicians contact the lab and let them know that there's clinical decision-making that is being made based on the test results. And so it seems like there was really no disadvantage to checking a titer with the 4th dose compared to after completion of a 5-dose series. Some people will require a 5th dose, but our understanding from having spoken to a lot of people who work in these laboratories is that it is not all immunocompromised people. Unfortunately, there's no good data that we could analyze to actually show that, though. Next slide. I want to thank all of the work group members listed here, especially Drs. Susan Moore and Dr. Deborah Briggs, who have been invaluable in terms of providing insight into some of the rabies immunology issues. And I can take any questions.
Thank you. We're now open for questions from the voting members. Dr. Paling.
Yes, thank you for a very good presentation. And it was very clear. I've got questions about the immunocompromised and titer checks. And I think it has to do with the fact that rabies is fatal. And so when you're going to do a titer check, what are the steps you have to do in order to get an expedited check, and where are those available around the nation? Is that easily available, or do you need to be in larger academic centers or larger medical centers, or where is that available? And what steps do you have to take to get an expedited titer?
Yeah, so there's 3 main places that do these titer checks: Atlanta Health Associates, Kansas State University, and CDC. One of our work group members actually used to lead some of those efforts at Kansas State University and said that people would call and say this is essential to clinical decision making. There was no questions or anything. This was routine for them to hear, and they would then expedite it and make sure that they had results reported back within 48 hours. And that certainly applies for CDC, and I think for Atlanta Health Associates as well. So basically calling the facility to ensure that they know that a particular sample that's been sent needs to have a rapid turnaround time. That's their normal process, and they're not. It's not like a one-off. They do this commonly. Was there another question that I missed about that? Rabies being fatal, titer check, rapid turnaround, I think was your question. Was there something I missed?
Yeah, I worry that the titer check could create inequity and could create barriers to just getting the vaccine. And so as I'm trying to weigh the risk benefit. I'm wondering, do we have data on the percentage of people who are immunocompromised and what their titers are like?
Yeah, no, unfortunately, that is data that we tried to collect to understand this. And a lot of these laboratories that are performing this testing don't get information about the patient, and so they don't know why the titer is being checked. It could be just a routine titer check for pre-exposure prophylaxis every 6 months for a laboratorian, or it could be someone who's having a post-exposure prophylaxis check because they're immunocompromised or because there was a deviation in the schedule. They aren't privy to that. They're not always privy to that, and there's no good way of analyzing that. But what we can say is that a lot of people who are so-called immunocompromised actually don't need more than 4 doses. And so from an equity standpoint, it would save those people from having to get that 5th dose. And the actual titer check itself is significantly less expensive. We had talked during the February meeting about the cost of the titer being around $50 or $75. And of course, there's additional costs for the clinical appointment to get your blood drawn and things like that. But that is compared to the cost of the vaccine, which is a lot more expensive than that. So from an equity standpoint, our feeling was that it would actually be preferable to check titers with the 4th dose instead of waiting until after the 5th.
Thank you for that answer. Anyone else from the voting members wish to make a comment or question? I'm not seeing any.
Can I ask a follow-up question?
Oh, of course.
Is there a consideration about giving people an option that you either give the 5th dose or you do the titer so that there's the flexibility depending on what is the most convenient for the person?
Even if you get a 5th dose, you have to have a titer afterwards because there are immunocompromised people that will need additional doses, and there's no way of knowing who those people would be. So we hadn't thought about that because it wouldn't be saving the patient anything. It would just be an extra vaccine dose that they may or may not have needed. Does that help?
Dr. Cotton?
Thank you for that excellent presentation. I would like to emphasize, as somebody who takes care of organ transplant patients and other immunocompromised hosts, that we really have such a paucity of data on this topic. So if there are mechanisms by which we could do some research, perhaps trend antibody titers or whatnot, it would be extremely helpful. Over the years, I've taken care of vets and other high-risk professions who've undergone or who are on immunosuppression, and it's really a black box. So any additional information on this topic, if there are people who could be doing that research, would be greatly appreciated.
Thank you for that comment. Anyone else from the voting membership? Anyone from the liaisons wish to make a comment or question? I'm not seeing any. Dr. Rao, do you wish to continue? Thank you.
Just a reminder here, the recommendations that were passed by the ACIP, this presentation is a review of the grade and the ETR for the pre-exposure prophylaxis in children in anticipation for a vote later this afternoon. And so I'm basically reviewing all that was discussed during the previous meeting in May as well as in February. So the recommendations that passed in February were for persons greater than or equal to 18 years of age. And they're listed here on this slide. You've seen them previously, but I just highlighted that they're for persons greater than or equal to 18 years of age. And then as Dr. Fry has mentioned, the number 3 risk group is what we were referring to when we're talking about booster doses or a titer option. These are people who who will have long-term risk for rabies. And so for that reason, in order to ensure long-term immunogenicity after a 2-dose pre-exposure prophylaxis schedule, should have either a titer checked between year 1 and year 3, and if it is low, a booster, or if it's not low, nothing at all, and be considered previously immunized for any future exposures, or they should have this option of a booster. which can be given as soon as day 21 and as late as 3 years. And we'd explained why the flexibility of that might be something that's desired. So then the proposed recommendations for today's vote, the wording is identical to what was passed during the February meeting, except for the ages that are highlighted here. We are proposing the same two for persons under 18 years of age. So just as a reminder, the most common reason, since we're talking about children here for this vote, the most common reason that children require pre-exposure prophylaxis is travel to canine rabies endemic countries. RIG is not available in some of these developing countries, and rabies vaccines may only be available in the capital city, resulting in a delay in PEP administration as people travel from rural areas to urban areas to get those vaccines. Children are at increased risk of multiple and severe bites, including to the face and neck, for various reasons. And the cost for, an important consideration for PrEP in children, though, is that the costs are usually out of pocket for persons who are getting them for travel purposes, and those can be very costly. Because the schedule recommends 3 doses of vaccine over the course of 21 to 28 days, that can be a large amount of money that is required in a short time period. So I've previously shown this slide during the February meeting when I was talking about the number of people who receive PrEP is about 60,535 per year based on a mathematical model that we used with the help of research provided by Bavarian Nordic. And in that group here, the travelers were really the largest of those groups, and comprised almost 41,000 of the people who get pre-exposure prophylaxis in a given year. And so this is a very important issue. The conclusions from the presentation about rabies PrEP and children during the May ACIP meeting was that for primary immunogenicity purposes, there's no difference between that in children compared to adults for any given schedule based on the data that we presented. I just want to mention that we did include data. We showed data from various rabies vaccines and various schedules in children, and there was a broad range of children included in there. And in response to Dr. Long's question of how many of those children were under the age of 2 years, it was difficult to say in all of the papers, but it looks like over 1,000 of those subjects were persons under the age of 2 years, and more than half of them were children under the age of 1 year at the time of the first vaccine dose. We also, beyond that, showed that what went into the grade table was one observational study that did include a lot of children, and it was a 2-dose series that showed 190 or 100% of children aged 5 to 13 years mounted titers greater than or equal to 0.5 IUs per ml, which is the cutoff. And that also was reassuring. As far as long-term immunogenicity goes, titers in children may stay higher for longer, and since boostability is not a concern for adults, we had said that we thought it should not be a concern for children either. Now, the impact of a 3-dose series on PrEP administration is what I want to show here on this slide. If your first travel clinic appointment is on a specific day that we can call day 0, and you get your first vaccine on that day, if you're traveling out, if you're flying out to a developing country where canine rabies is endemic on day 10, then it creates problems because rabies PrEP would typically be administered, but it is not administered because there's not enough time to give that 3-dose series, which is the 3rd dose is on day 21 or day 28. And so if there is a hypothetical exposure that occurs during that travel, then RIG and a 4-dose PEP is indicated. And as we've already mentioned, there are some challenges with accessibility of these when we're traveling. If, on the other hand, we have the 2-dose series of PrEP for children, then at the time of that first clinic appointment, then the first dose of PrEP can actually be administered. The dose 2 could be given on day 7, which is before the person travels. And if they do have a risk for long-term risk for rabies beyond 3 years, they will have that option of the titer or the booster dose, and the booster could be given after they return from travel or any point before 3 years. And then if they have an hypothetical exposure on their trip, they would only need the 2-dose vaccines and no RIG. which would make things a lot easier. Now, the implications of not aligning the adult and pediatric PrEP recommendations were also presented at the May meeting. Discordant recommendations could mean that parents may get vaccinated, but children would not, and children are the ones who are believed to be at a greater risk than adults. It also would set a precedent. There's no previous rabies PrEP or PEP recommendations that have involved a different series for adults compared to children. And it could result in people thinking that there is a concern about the number of doses for children when in fact the work group wasn't worried about that. And now I'll get into the ETR for the two policy questions. So starting with the ETR for the first was about primary immunogenicity. And you might remember this is the actual PICO. The question is, should a 2-dose pre-exposure prophylaxis or PrEP series involving HDCV or PCECV IM 0-7 days replace the 3-dose series IM 0-7, 21, 28 days for children for whom rabies vaccine PrEP is recommended? And the population we're talking about for today's vote is children for whom rabies vaccine PrEP is recommended. The intervention is a 0-7 days rabies vaccine PrEP schedule. The comparison is the current 3-dose series, which is 0-7, and the third dose at 21 to 28 days. And the outcome was primary immunogenicity only because there have not been safety concerns with these vaccines that have long been available in the US. So the problem itself is that rabies is nearly always fatal. As you all know, PrEP is an important component of preventing human rabies in the US. The Yellow Book specifically mentions that children are at a particular risk for rabies because they have inquisitive nature and attraction to animals, might be unable to read behavioral cues from dogs and other animals, and it might have an increased likelihood for severe bites to high-risk anatomic regions like the head and face because of their short stature. And so children do often travel to canine rabies endemic regions, for example, visiting grandparents. Rabies modern cell culture vaccines are very effective, though, and so that's why pre-exposure prophylaxis should be considered in children. So getting to the evidence to recommendations framework, the benefits have been previously presented. Microphone is not working. Somebody's saying that they can't hear me.
We can hear you.
Okay.
We can hear you.
Okay, I'm going to ignore that. All right, so benefits. How substantial are the desirable anticipated effects? Minimal. 100% of people seroconvert for the proposed and for the previous schedule. And here we're referring to the comparator being the 3-dose series. And that's why we're saying there's minimal benefit for a 2-dose compared to a 3-dose in terms of the seroconversion. Harms, how substantial undesirable anticipated effects? Minimal. There's no expected safety concerns. Benefit to harm ratio, do the desirable effects outweigh the undesirable effects? They actually favor both because they're minimal for both. Overall certainty of the evidence for the critical outcomes. We found that there was moderate certainty of the evidence, or level 2, due to concerns for risk of bias, which I'll talk about in the next few slides. But the grade table basically showed a moderate certainty of evidence. So now I'll present some of that information for the grade table. We identified 2 studies in our systematic review, starting with the randomized control trials. And there were 2 of these RCTs that compared a 2-dose to a 3-dose primary series across both studies. 100% of participants met the outcome of interest. There was unclear reporting of randomization and allocation concealment in both trials, which led to some concerns with risk of bias. We also looked into observational studies, and we identified 10 additional studies that compared a 2-dose to a 3-dose primary series. We treated them as observational studies, because, even though they were originally designed as randomized trials, because we broke this randomization to extract the pertinent data. The quality of the studies were evaluated with the Newcastle-Ottawa scale, and there were minimal concerns identified in most studies, and there were minimal concerns identified in 3 of these studies, and no concerns identified in the rest. The concerns for risk of bias were factored into the grade table. And what I've highlighted here are the studies in the observational data that included people who were close to the age of children, I suppose you could say. 18 years old was the lower limit in the Kramer paper. 17 was the lower limit for the J. Geroncip paper. And the one that is the we highlighted at the last meeting was the Sabcharian paper, 1999, where children between the ages of 5 and 13 were the subjects included. And just as a reminder about that particular study, 190 school children were enrolled, and 100% of those children had antibody titers greater than or equal to 0.5 IUs per ml. The portion in the box here is the part that's relevant to our conversation. The antibody titers, you can see 100% had titers greater than or equal to 0.5 IUs per ml. And the reason they have here listed 0.15 IUs per ml is just that that is roughly what the previous ACIP recommendations might come out to, but as we previously discussed, the ACIP guidance will state that 0.5 going forward will be our minimum antibody titer. So this is the evidence profile of the grade assessment for the outcome of immunogenicity as measured by a titer at or above 0.5 IUs per ml. We've assessed the body of evidence from the RCTs and the non-randomized studies separately. Because of the concerns with unclear reporting of randomization and allocation of concealment, we rated the RCTs down for risk of bias, but we had no other concerns of the certainty of the evidence, and that's why we landed on a moderate level or level 2 certainty about immunogenicity. 264 persons in the 2-dose arm and 3-dose arm achieved 100% seroconversion. The second line of this table shows our certainty level in the evidence of immunogenicity for the non-randomized studies. Because we actually, with the randomized trials, had a level 2 certainty, we didn't really have to do the grade table for the observational, but we did go forward with that, and particularly because there was that one study that involved children, it is comforting to see that we found here level 3 certainty and that is because they started as non-randomized studies and therefore started at a level 3, and we had no additional concerns and no reasons to upgrade, and therefore it remained at that level 3 certainty level. So moving on to the remainder of the ETR, values. Does the target population feel that desirable effects are large relative to undesirable? Yes, the desirable effect is being vaccinated from rabies. Values, is there important uncertainty about or variability in how much people value the main outcomes? No, the target population values protection of children from rabies because this population is at higher risk than adults during travel. Acceptability, is the intervention acceptable to key stakeholders? Yes, shorter schedule preferred by patients and providers and will enable more children to be vaccinated before risky travel. Resource use, is the intervention a reasonable and efficient allocation of resources? Yes, travel vaccination costs are typically out of pocket. Fewer doses results in lower costs for individuals, and also rabies vaccine shortages have occurred in the US, so using fewer doses will result in efficient allocation of resources. Equity, what would be the impact on health equity? Probably equity would be increased because of decreased costs. Feasibility, is the intervention feasible to implement? Yes, a shorter series than the current series would actually be easier to implement before travel. Having trouble advancing. Can you advance for me, please? And the balance of consequences led to the work group saying desirable consequences clearly outweigh undesirable consequences in most settings. And the recommendation is, as shown previously, the ACIP recommends a 2-dose 0.7 days intramuscular rabies vaccine series in immunocompetent persons less than 18 years of age for whom rabies vaccine pre-exposure prophylaxis or PrEP is indicated. Now on to the second recommendation that will be voted on. This is about long-term immunogenicity. The PICO here, the policy question is, should an IM booster dose of rabies vaccine, and that's PCECV or HDCV are the two vaccines in the US, be recommended as an alternative to a titer check no sooner than day 21 and no later than 3 years after the 2-dose pre-exposure prophylaxis series, IM 0.7 days, for children in the number 3 risk category of people who receive PrEP. And we previously went over who the children in the number 3 risk category would be. They're the travelers who might be visiting grandparents or have some other reason that they might be repeatedly going back to a country with canine endemic rabies beyond the 3 years from their primary vaccination. The intervention is day 21 to year 3 rabies vaccine booster after the 0-7 days rabies vaccine PrEP schedule. Comparison is no rabies vaccine booster after the 0-7 days rabies vaccine PrEP schedule, and the outcome is long-term immunogenicity. So the problem here is some children make trips to developing countries beyond 3 years. Immunology suggests that they would have an anamnestic response if an exposure occurred beyond 3 years. And WHO approved that 2-dose series for this population without titers or boosters for this population. But the work group wanted to be as conservative as possible. There isn't data beyond 3 years, and therefore to ensure long-term immunogenicity for the 0-7 days series, there is strong data for long-term immunogenicity up to 3 years. There is data that shows that the titer at greater than or equal to 1 year is a marker of long-term immunogenicity, and that is why the work group put all these pieces of information together to propose either a titer at 1 to 3 years, and if that titer is over 0.5 IUs per ml, then nothing would need to be done. If it was lower, they would boost and confirm that there was an appropriate response. Or for people who would just like to cut to the chase and get straight to the booster dose, they could get a booster or that third dose. It can be considered sort of like a flexible 3-dose series, a flexible schedule for what is currently recommended. If they could get the vaccine as soon as day 21, which would make it the same as the currently recommended 3-dose series, or they could wait until much longer, up to 3 years, potentially fraying costs. I mentioned this previously. Long-term immunogenicity, there is hopefully some data coming to show that a 2-dose series might be enough, or at least some data evaluating that. There was a study that was published in January of this year, and it was a very small group of people included here, but we're hoping this is promising for more data that might come from Europe. In that study, there were 6 persons who received a 0-7 days IM series that were evaluated 10 to 11 years later. 3 of them were male, 3 were female. They were aged 34 to 46 years. 5 had titers greater than or equal to 0.5 IUs per ml even before a booster was given, and all had a 4-fold increase in titers after a booster. So there's more data that hopefully comes from Europe, and hopefully we'll be able to better assess whether a 2-dose series alone is all that is needed and neither titers or boosters are necessary. But until then, we have this second recommendation. So then the ETR, the benefits, how substantial are the desired anticipated effects? Moderate is where the work group landed. Flexibility in receiving that titer check, and only a booster if indicated versus a booster over a broad time period, i.e. as soon as day 21 and as late as 3 years, would provide flexibility. 100% of subjects mounted an anamnestic response to booster at 1 to 3 years. Harms, how substantial are the undesirable anticipated effects? Minimal, because there's no expected safety concerns. The benefit to harm ratio favors the intervention. The overall certainty for the evidence is level 3 or low certainty of evidence. The same 2 studies that were included for the previous grade table were also included in this study. And, oops. I'm sorry, just a moment. Things are popping up on my slide. Okay. This is the evidence profile of the grade assessment for the outcome of duration of immunogenicity as measured by a titer at or above 0.5 IUs per ml after booster. The best available evidence came from the single arms of 2 trials and therefore was treated as non-randomized, and no additional concerns with the body of evidence existed. And that is how we ended up with level 3, because this data was observational. That is where we landed. Going back to the ETR, the target population sentiments, does the target population feel desirable effects are large relative to undesirable? We said probably yes, because stakeholders want to avoid acquiring high-stakes infections. Children have many more years ahead of them and might make future travel plans. A booster provides reassurance that outweighs any inconvenience. The next, target population sentiments, is there any important uncertainty about or variability in how much people value the main outcomes? No, the target population values protection from rabies, and there's likely no important variability. Acceptability, is the intervention acceptable to stakeholders? Yes, stakeholders accustomed to accommodating a third dose of rabies vaccine, as is currently the schedule, will find it acceptable to have a booster as an option, particularly given the flexibility for when that booster can be given. Resources, is this a reasonable and efficient allocation of resources? Yes, persons who do not have sustained risk for rabies will not require the booster. It's only the people that have that sustained risk. And additionally, because of the flexibility and the time point for this booster, it can be arranged at a time when there is no shortage of vaccines. Equity, what would be the impact on health equity? It would be increased because some prep costs are out of pocket, and because travelers in particular, it's out of pocket. But because titer is offered as an option, and equity could be resolved by choosing that option. Additionally, children without sustained risk for rabies will not need that booster or titer, and those who do require it could defer receiving and paying up to 3 years later, diffusing the costs over a longer time period. Feasibility, is the intervention feasible to implement? Yes, administrators could opt to schedule booster dose at the time of primary vaccination if there is a concern for travelers not remembering to receive the booster dose. And here as well, the work group felt the desirable consequences clearly outweigh the undesirable consequences in most settings. And the recommendation is listed here. ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent persons less than 18 years who have sustained an elevated risk for only recognized rabies exposures, i.e. those in the risk category number 3 of rabies PrEP recommendations table. The booster should be administered no sooner than day 21, but no later than 3 years after the 2-dose PrEP series. So we're talking about children here. It should be less than 18. And I've listed the recommendations, both of them again on this slide. These are the 2 that will be voted on later today. I think that is all.
All right. We'll open this up for questions or comments. We'll open this up then. Does anybody have any questions, comments? Dr. Talbot, please.
Please pardon my ignorance, but I believe it's on slide 8. You talk about that if a child can't get all 3 shots prior to going on the flight, that they can't even start the dose series. Is that true?
Yes.
Why could a physician not give them 2 doses and then give the 3rd on return?
So the pre-exposure schedule that is currently the ACIP recommendation is 0, 7, and then the 3rd dose at day 21 or day 28. So physicians, travel medicine clinics have not been initiating pre-exposure prophylaxis if they cannot administer that series according to that recommendation. I know Dr. Elizabeth Bennett, she's on the phone as the travel medicine person who's on our work group, and is maybe she could weigh in on that.
Well, but I guess before she speaks up, I mean, if you leave on day 10 and you on a 10-day trip, you would be back. So I don't understand why it couldn't be done.
Yeah, I mean, if for some reason they're returning, so the current recommendation is a 3-dose series, and so people assume you have to get all 3 doses before they travel, or they're not going to be protected such that they are not going to be able to get just a 2-dose PEP series if they get exposed in the field. So that's the thought process is that that's what the thought process is for the 2008 recommendations. But what we're proposing now with a 2-dose series is that they could travel after after 2 doses, because they would be considered immunized for up to 3 years with that 2-dose series, and then that 3rd dose could be given at any point up to 3 years. It could certainly be scheduled for soon after they return from their travel. It would not need to be given before.
I guess my thought is that you could give them 2 and they could get that 3rd whenever without actually changing the number of doses in the series. But I guess that would take a fair amount of education for the providers.
Yeah. Dr. Bennett, do you want to say something? Excuse me, it's Barnett. Dr. Barnett.
Actually, this is Mary Wilson. I'm filling in for Dr. Barnett, who cannot be here today, but I also am active in the International Society of Travel Medicine. But it is correct that travelers who in the past could not receive a full series would typically decline to receive any of the vaccines. So I think having this alternative schedule where it will be possible for people to receive 2 doses in this way will increase the uptake overall of vaccine and those who really can benefit from it.
Thank you for saying that.
Welcome.
Dr. Kimberlin.
David Kimberlin, AAP Red Book. Could you go to the next to last slide, the one, or I should say it's the one right before the acknowledgements? Perfect. The only place on this slide that the word children or child appears is in risk category 3. And I think if I understood, Dr. Rao, your response to Dr. Talbot's question just a minute ago, I believe you acknowledged that a child could receive the booster dose, 21 days to 3 years after dose number 2, which would also fall into risk category 3. Is the intent, though, that children can also be in risk category 4 if it's a one-time trip?
Yeah, that's correct. You're right, Dr. Kimberlin. We can, I see what you're saying, that we should account for that.
I'm not sure I'm actually advocating for that, but I like it better when children, I thought you did a phenomenal job at the May meeting in really laying out the data for seroconversion, such as they are, but really doing a deep dive into that for pediatrics, and I appreciate that very much. I personally still would like that option of a 3rd dose for a child, period, and option number 3 does that. But if children are meant to be in option number 4, I probably personally would still be okay with that, I think. But I do think it warrants consideration by the full committee as to are children only in category 3, risk category 3, or are they in either category 3 or category 4, again, depending on sustained versus unsustained exposure.
Yeah, I mean, they also could be technically also in risk category number 2. It's just most of the children would probably fall into 3 or 4. But if, for example, a 17-year-old or a 16-year-old was doing some summer work that involved working with a bat biologist, for example, then they might fall into that risk group too. But if it's limited to just the 2 years and they're not doing the summer work endlessly for 3, 4, 5 years, then they really wouldn't need tighter checks or like someone whose occupation it is to actually do that work. So I think where this ends up landing is almost all children are going to be in either 3 or 4. I suppose there could be situations where they could fall into 2 because they are doing summer work for years and years at a time. But most of them would fall into risk groups 3 or 4, and we can modify this table to indicate that children would fall into any of those groups.
All right, thank you.
Are there any other comments from either the voting members or the liaisons? Okay, then let's have the the wording for the 2 proposals up again, please, Chris.
That's the next slide.
backwards, I think, is it not?
We have it.
Okay. Dr. Cohen, is it possible for the ACIP members, voting members, to make a motion with both policy questions on the same slide at the same time, or does each question have to be?
No, we can do both at the same time, don't you think? Yeah, that's
Okay.
totally fine, but we just don't have them on the same
I
slide.
thought we did, but we didn't. Okay.
And we did in the previous presentation.
That's what I was asking for.
Yeah, we pulled that one up. Yeah, the Dr. Whoever presented had it in the opening, right? Yeah.
I'm just trying to streamline the voting process. Just a second, folks. So while I bring them up, I'll read the first policy question, which is ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent individuals. Yeah, here we go. This is the one. This will make it much easier. Okay, so let me go forward then. So the proposed recommendations, and we're going to motion and second both at the same time, are for the first one, ACIP recommends a 2-dose 0 to 7 days intramuscular rabies vaccine series in immunocompetent persons less than 18 years of age for whom rabies vaccine pre-exposure prophylaxis PrEP is indicated. Next, ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent persons less than 18 years of age who have sustained an elevated risk for recognized rabies exposures, i.e., those at risk, category 3 for rabies PrEP recommendations table. The booster dose should be administered no sooner than day 21, but no later than 3 years after the second dose PrEP series. So, do I have a motion? Dr. Paling.
Yes, I'd like to make a motion to accept both recommendations as written.
Thank you. Hands down, and we'll ask now if anybody can please give a second. Dr. Sanchez.
Dr. Mayer, I'd like to second that, both of those.
Thank you very much. All right, so these will go forward and we will vote on them following the public comment session, which, so we are going to give everyone 6 minutes of a break, and then we'll be back to begin the public comment session.